Good afternoon, everyone, and welcome to today's webinar focusing on thriving places post-pandemic, the relationship between spatial planning, health, and well-being. My name is Caroline Creamer, and I am the Director of the International Centre for Local and Regional Development, the ICLRD, and also a Research Fellow with Maynooth University Social Sciences Institute, and I'm delighted to be moderating today's webinar. This is the second event as part of ICLRD's monthly webinar series on post-pandemic planning for people and place, a series that is being run from May until November. Today's event is being held in partnership with the ICLRD partners, namely Maynooth University, Ulster University, and the National Centre for Smart Growth at the University of Maryland. By way of housekeeping, today's event is being live streamed through Maynooth University Social Sciences Institute's Facebook page. A copy of the recording, together with speaker presentations, will be available on the ICLRD website after the event. That's www.iclrd.org. And if tweeting today, please use the hashtags ICLRD webinar or thriving places. So in terms of context for today's event, we are considering today if the focus of spatial planning has come full circle, from its origins rooted in growing concerns with public health and slum conditions across industrial cities in the 19th century, to a renewed interest in the relationship between spatial planning and health and well-being in the 21st century. This interrelationship between planning and health was brought to the fore and possibly even concretized during COVID-19, when the international narrative positively turned to building back better and creating resilient places and livable communities that were grounded in sustainable development principles and the concepts of healthy places, nature-positive places, and livable places. But what do we mean by livability? A sharp but very succinct definition by Martino and his colleagues speaks to how spaces can fulfill the expectations of its inhabitants for well-being and quality of life. This afternoon's webinar seeks to explore some of the key movements that have emerged or have gained greater traction, increased significance in a post-pandemic planning context. Both through the presentations we will hear shortly, and indeed through your own reflections and lived experiences, key discussion points will centre on where and how does health and well-being fit into spatial planning policy and research? What have the responses to the socio-economic and health threats of the COVID-19 pandemic taught us as designers, providers, and users of space and place? And has the past 2+ years shed any light on the type of place we want to live and work in? And can we build on that momentum? We have three excellent speakers today. We'll firstly be joined by Dr. Gavin Rafferty, a lecturer in spatial planning and development at Ulster University, who will speak to us on the transformative health and regeneration initiatives for enhancing livability and well-being, reflections from the Belfast Thrives programme. Gavin will be followed by Erin McFeely, who is Chief Executive of the Developing Healthy Communities NI, speaking to who makes a healthy city and learnings from health in Derry and Strabane. And lastly, we'll be joined by Katrina Mullen, an independent consultant and senior research fellow with ICLRD, who will be speaking to negotiating the complexity of health in cross-border territorial cooperation. So with three excellent interventions to follow, this will then be followed by an open discussion. And we ask you to please post your questions throughout this afternoon's event during using the Q&A function located at the bottom of your screens. Today's proceedings will then be pulled together by our respondent, Audryn Reid from the School of Environment and Planning in TU Dublin. And so, without further ado, to kick us off, Gavin, I'm going to hand the reins over to you. Hi, Gavin.
Hi, thank you very much, Caroline, for that. Just begin to share my screen. Hopefully everyone can see that now. Okay, good afternoon, everyone. As Caroline said, my name is Gavin Rafferty. I'm based at Ulster University, and this presentation really is a reflection on a bit of detail about, but also reflection on the Belfast Thrives project, which really stands for transformative health regeneration initiatives for creating increasing viability, equity, and sustainability. So it's really dealing with the concepts that Caroline has referred to around livability and well-being. It is a project that is really focused on, it's really a pilot project that's collaboration between colleagues at Ulster University and what we call the Urban Research Lab with colleagues in Belfast City Council, particularly from the Regeneration Department. And also working in collaboration with the Department for Infrastructure, and some additional funding has come from the Department for Communities for this pilot project. You can see the project team down below, which I'll not read everyone out, but it is a collaboration, as we say, between researchers at the university and practitioners. The aim of this Belfast Thrives project was to critically reflect on place-based initiatives, some which had been in, I suppose, planning stage prior to COVID, and some that are a response to COVID. And also to draw some international lessons as well as local lessons for advancing livability and well-being for Belfast. And when we talk about Belfast, the map there on the right-hand side of your screen really is, we're talking about the city centre, not Belfast city-wide. So the key objectives of this particular project was to really work in collaboration with our practitioners to examine these international lessons on place-based regeneration, looking at elements around community engagement, but also data sharing that's happening elsewhere that tries to help bridge that gap between planning practice and health data as well. And one of our colleagues listed there in the previous slide is more of an expert in sort of the health and data side. We're also were keen to ascertain public perceptions on the extent to which Belfast city centre supports livability and well-being, to try and get an understanding what people currently believe works well in Belfast, and also how does it, and to what extent does it support healthy lifestyles and advance health and well-being. And we also wanted to identify areas for improved cross-sectoral data sharing and well-being, data in the broadest sense, not just statistical data, but also knowledge and sharing of information that will hopefully advance our understanding and promoting well-being, sustainability, and resilience. So the methodology for this particular project, which ran from about last year, was a 6-month funded project, but actually it ended up being much longer in terms of the ongoing conversations with practitioners to distill the learning, and we'll come to that some of the reflections at the end of this presentation. But it's an action-based research project, which really basically means we're working with practice to see if we can inform the action part of that, and so the research is trying to be translated into practice as we move, as practitioners continue with their daily work. So we wanted to examine, as we referred to previously in the objectives, things like stakeholder perspectives and livability, look at international precedents and examples around that, and focus in on 3 city centre transformation projects that have emerged, 2 of which have emerged from COVID, and 1 which has been in operation prior to that. It's a mixed methods approach, like any good research project. We're looking at literature review, what's happening out there in the field. As part of our other methods were to, early on in the project last year, was to start with an international symposium to look at case studies, to get the conversation started with local practitioners around what's happening in this area around spatial planning and city development and health. Also, we undertook some qualitative research, which really consisted of an online survey, which I'll present some findings on later, and also some stakeholder perspectives around the theme of the project as well. So really the project, to quickly cover some of this, the beneficiaries and stakeholders, obviously we're trying to engage the general public and those engaging with Belfast, living and working there, to get their views. Also to hopefully some of the material from the findings that we're currently disseminating will be used for policymakers. Obviously our project partners are key beneficiaries of this work in terms of trying to work with them on the ground, so to speak, to inform policy practice and even future research in this area. Importantly, we have also incorporated and included our students on our courses here at Ulster University, so they're involved in this real world experience and trying to shape their understanding of how planning plays a role, and to what extent it can play a stronger role in improving health and wellbeing outcomes. Many of you are probably familiar with Belfast context, so as not to dwell on this too long. But obviously the city itself is a population there roughly around about 400,000 people. There's been huge depopulation of the inner city due to the context within the city, the mass movement out into the suburbs. But some of the key information there is that from the local development plan is that it's one of the youngest cities in Europe in terms of nearly a third of the population under 21. We've also a growing aging population, as you can see there, and many social issues that what the city has to deal with in relation to, and also in addition to, the health and well-being agenda. As Carling has referred to, it's quite interesting that we see spatial planning, if you like, reuniting with its with the health agenda. As Carling outlined, planning did emerge from obviously the health concerns within with massive industrialization and movement towards the cities. But we are seeing spatial planning, at least in policy terms, trying to articulate a role for itself in improving health and wellbeing outcomes. And in the Northern Ireland context, the strategic planning policy framework clearly states as its first core planning principle is about improving health and wellbeing, as well as the other ones listed on your screen there. Some unique ones, I suppose, to the Northern Ireland context by creating and enhancing shared space alongside what we would tend to see the planning system to do in terms of supporting economic growth, delivering good design, and improving and preserving the built and natural environment. But it is quite interesting, I suppose, an advancement in the way that we have got an articulation that planning has a role to play in improving health and well-being. For the city itself, Belfast City is also quite a unique policy context in that there's been a recent bolder vision for Belfast articulated as a jointly developed between Belfast City Council with the Department for Communities and Infrastructure, which outlines the various principles there, as you'll see on your screen. We're trying to advance well-being, prioritise cycling, walking and public transport, creating a healthy, safe and green streets, and removing barriers to movement that exist in our urban fabric. And so it's a further expression of trying to enhance livability, we might say, and deal with a complex range of social, economic, and environmental problems for the city. As well as trying to understand the policy context for this work, like any good research project, we had to conceptualize what we were looking at and understanding of some of the terms. And what we were finding in a lot of the literature around health and well-being is also an expression of this term called liveability or livable communities, which you can see there has been defined on your screen, which really is about trying to, in addition to what Carling has said about the other definition, is really creating safe, attractive, socially cohesive, and inclusive, and environmentally sustainable places. Covers a wide range of themes, for you, if you like, in terms of mobility, employment and education, the quality of our open spaces, access to services, for example. And so in our project, we were using the lens of livability to understand and appreciate some health and well-being dimensions, and testing that, if you like, with our practitioners to the extent to which livability is a valuable concept and tool to be deployed, and in I suppose advancing our understanding around how place shaping functions, not just purely planning, but planning, development, and regeneration functions, and advance health and well-being, as they are inextricably linked in terms of the quality of life and well-being. In addition, to add to what Carling has said, in terms of the preamble for the workshop, the SEM webinar this afternoon, we are seeing in many pieces of policy or think tank literature and academic literature is referring to the increased reference to health and well-being. There's a question still remaining: to what extent is that rhetoric, or is it happening in practice? And that's something hopefully we'll debate later. The urban environment is well argued that it plays a key determinant role, I suppose, in of people's health, with various models, understanding that in terms of Barton's model of social impacts, social determinants of health, which gives spatial planners and others outside the medical field an understanding of the variables that we should be thinking about that play a role in advancing or diminishing health and well-being of our inhabitants. So things like urban forum, service provision, all to a certain extent support health and well-being. And again, more recently, COVID pandemic has, highlighted that that there can be rapid change happening, and also that's possible to be delivered as well. So in the specifics of our project, as I mentioned, we're looking at 3 case study areas, as you'll see there on your slide. One, there is the pre-COVID intervention, which was the redesign of Cathedral Gardens beside the Ulster University Belfast campus as a bit of a temporary use, meanwhile use. Also then the proposed living quarter business improvement district bid to transform Brunswick Square into this Brunswick Street social, like a social hub. That's currently actually near enough finished. And also the Department for Infrastructure's cycle lanes and pop-up cycle lanes during the pandemic. So the way we've approached analysing that, other colleagues have really applied a modified version of the place standard, also undertook participant observation, COVID compliant, and also to try and reflect on the extent to which these types of initiatives promote health well-being outcomes, and also to try and understand the degree of stakeholder engagement in these initiatives as well. As I mentioned, the international symposium that we had earlier on covered a wide range of topics to try and shape our understanding of this work and this project. And you can see there a list of different speakers that we had covering a range of topics around things like data and how we use data, health data to motivate and support policy and practice from the US context. Other initiatives such as Seattle Streets Sync, for example, which is trying to provide facilities for the homeless and others to improve sanitary conditions during the COVID period, and lots of different and innovative approaches that we're dealing with health-related matters in the urban context to kind of inform our thinking and to kind of spark ideas around what's happening elsewhere. The next few slides I want to try and draw out in the time remaining just some key findings from the survey that we undertook. And really the survey was trying to capture livability of Belfast, how the city is currently performing for its users through a range of livability themes that were based on the quote earlier. And also look at these recent changes and transformations to the city centre. So the responses, we got about 260 responses. You can see the spread there across really majority from the public, some from other communities of interest, if you like. For example, gender balance was pretty well split there. And you can see the age profile there as well, although we're missing some younger and older voices, if you like, from the survey, which is important to note. But an interesting, I suppose, point or learning from the survey was that many people, there's a very strong percentage there, believe that the Belfast city centre has a huge role to play in supporting healthy lifestyles for citizens, not surprisingly. But also there's a bit of a contrast in terms of their extent to which they believe the city currently does that. If we distill some of the percentages there from those that have responded, you can see that there's still a high percentage saying very little, not at all. Although there's some middle ground there of somewhat in terms of 41%, which shows promise in terms of people believing that there are currently initiatives going on that are advancing healthier lifestyles within the city. Some other key snapshots, I suppose, from the survey is that, looking at the various themes, but just highlighting 2 here around transport and connectivity. Generally the city is accessible given its size, however, in terms of reaching a destination. But while 63% of respondents perceive the city to be safe to walk, 63% also feel that the city does not provide enough supports walking and cycling. So there's contradictions and some of that need maybe to be drawn out and understood better for future interventions. Also looking at themes around housing and services, a strong majority, 69% responded that the city centre is not an attractive place to live, with 51% feeling the city does not provide quality housing that is affordable to buy, or an even a higher percentage of 61 says that there's a poor value for money in relation to rent, for example. And it doesn't really support inclusive places for people like families and young children. So some other quick survey results are really, we asked about people's ability to participate in decision making shapes the city, and you can see there clearly that there's many disagree that they're able to contribute towards the decisions, that it's very difficult to engage in planning processes, but they would like to be more involved in that. The stakeholder workshops then, again, this is a quick, rapid run through of some of the key headlines from that. You'll see the range of groups that we engaged with across business, professional groups, councils and third sector. There's a range of viewpoints that were insightful for us in terms of the complexity around livability, and again, how that's difficult to define and shape government direction and policy and actions. There's a need for more intersectional sectional approach to planning and development, and gathering information about how people do not use the city, and really to what extent that impacts their health and well-being. There also seems to be a general perception from those that participated in the workshop that while there's been advancement in policy, still very much these instruments that shape place, such as planning, regeneration and development, there remains a very technocratic exercises dominated by these economic and managerial sensibilities or approaches or logics. And also there's a need maybe for the way we collect and collate and share data and evidence is something that's problematic. So getting to my conclusions, hopefully not too over time, but really, I suppose what we have gleaned from the project and spoken to our practitioners is a complex completing variables around livability that help us understand health and well-being, but we do see, and our practitioners do see, a value in that livability lens or concept to understand health and well-being, which can be quite nebulous and complex. Also, there's limited data sets in Northern Ireland that are available to many, including academics and other sectors, to really better understand how the health of our population and the linkages then to the built environment. Alongside that, there really needs to be stronger policy alignment across sectors to explore complementarity across policies and professions, the sharing of data and information, nurturing shared responsibilities, and indeed possibly even linking budgets as well. Also, points around engagement are quite important in terms of getting a better understanding of who's using the city and why, and how it actually benefits them in terms of health and well-being, and therefore greater experimentation with meaningful inclusive engagement would be something that we'd recommend. Also, and again, can be controversial, but the need maybe to elevate health and well-being outcomes to be on a par with, some might not like this, but also maybe prioritized over economic outcomes to really give some strength and weight to those. Linked to that, I suppose, is maybe the need to consider an explicit well-being outcomes framework for planning and regeneration functions that will link better to other developments in that area, such as community planning and its outcomes-based accountability. And finally, it does, I think, what we have found, and it does echo probably what other researchers would say too, that raises questions about the assumptions around planning and development, the logics, ideas, the concepts applied in it, whether they're sufficiently accurate or developed enough to inform and guide actual positive change and livability going forward, which is what we're currently striving for. So that's me, and I look forward to the questions and discussions later.
Thanks very much, Gavin. That was truly informative presentation, and I think struck by a lot of the kind of key themes coming out there in terms of the complexity of that interrelationship between planning and health and well-being, the importance of the collaboration and bringing together the mix of partners and stakeholders to the table, and indeed capturing the citizen's voice, and also then going back to the core principles of planning and ensuring that they are at the heart of the discussions and where it is we want to go. And I think we're going to see quite a number of those themes now reflected in our next presentation. So we're now moving over to Erin McFeely from the Developing Healthy Communities Northern Ireland programme. So over to you, Erin, and thank you very much.
Thanks, Caroline, and thanks for asking me to be here today. I think someone's going to share my slides for me. Is that possible? Or start?
coming now.
Oh, that's brilliant. Thank you very much. Lovely. So good afternoon, everybody. And for those who are not familiar with our organisation, we are a third sector organisation that has played a strategic role supporting and promoting the health and well-being of people and communities for 30 years this year. And we do this by connecting people across sectors and areas of interest, championing collaboration and innovation, and we run a number of projects which play a part in advocating, influencing and capacity building in order to tackle health inequalities. So if you don't mind moving to the first slide, please. So for over 30 years, our core purpose has been health promotion through collaborative action. Oh, sorry, just back one step, if that's okay. Yeah, has been health promotion through collaborative action, or to put it more simply, working together to make it easier for people to live healthier lives. We started out as the Derry Healthy Cities project, which was an innovative project even 30 years ago, which brought together leaders from council, statutory health agencies, public health, housing, community and voluntary sector and others. And although the organisation itself has broadened its scope and changed its name since our inception there, we still facilitate what's now known as the Derry and Strabane Healthy Cities Initiative. And that's what I'm here today to talk to you about. So the Healthy Cities Initiative is a partnership project, and it brings together the council, the PHA and other community planning partners in our area. And as you'll know, that partnership approach is more crucial than ever, given the challenges that we're facing in today's society: climate emergency, cost of living crisis, compromised peace and security, and as well as the challenges that we have in terms of the delivery of our health services. And I think it's fair to say that no one agency can achieve the level of transformation that is needed to tackle some of these challenges today. So our kind of motto is that complex problems require complex partnerships. And I think when you listen to the diverse perspectives of business, education, and those working to improve our physical and our built environment, health is a unifying topic, and one which underscores everyone's objectives. Everyone cares and everyone wants to do what's best when it comes to health. So if I talk a bit about what we mean by a healthy city and district, Derry City and Strabane, first designated to the World Health Organization European Healthy Cities Network in 2009, and we've successfully completed phase 5 and phase 6 of the designation, and we're delighted that we've recently had our phase 7 designation approved. So Healthy Cities is at its heart a political and value-driven network, and it's designed to drive innovation and collaboration in order to tackle health inequalities at a local level. And we do this by focusing on the wider determinants of health and drawing on international best practice. So it's a high-level, multi-agency agenda, and it is aligned to our strategic agendas in the city and district, including our inclusive strategic growth plan and the City Deal Fund, for example. The Mayor is the lead signatory to the Healthy Cities Network, and our recent application for designation was approved by all elected members in the council. And in Derry and Strabane, the Healthy Cities Initiative is integrated into the Strategic Growth Partnership, which is the partnership which oversees all aspects of community planning in our area. And this is a recent development for the Healthy Cities Initiative, but it's one that we are very positive positive about and feels that really that body is the appropriate forum, given its cross-sector representation and its strategic and shared vision for the city. So as you can see here from the definition from the World Health Organization itself, being a healthy city and being a designated healthy city is not about being perfect. We know the scale of the health inequalities that exist in our city and district, but it does mean that we are demonstrating that we are committed to tackling these and striving to be better. So just don't mind going on to the next slide, please. As I mentioned, the important thing to note about the World Health Organization model is it really takes a broad, holistic and integrated view of how cities can plan for improving health. And particularly in the context of driving our recovery from COVID-19, the Healthy Cities framework really demonstrates that health and economy are two sides of the same coin, and promotes a coming together of business, community and statutory agencies in order to improve conditions for all. So this Healthy Cities model that you see here is often referred to as our 6 Ps model. And our interest is really in how we translate this into our local situation in Derry and Strabane. And we're pleased that our application for Phase 7 designation demonstrates that we are successfully embedding this model. So as you can see, peace, planet, place, people, participation and prosperity are at the heart of what we strive to achieve. Next slide, please. So, is there one before that? Sorry.
No, it's just
No. Oh, right. Okay. Maybe not. Sorry. I was going to just briefly run over then. I can just speak about it, but I'll briefly run over some of the points that enabled us to achieve successful designation to Phase 7. And this included the vision that was embedded in our strategic growth plan. It included specific projects, both at a large and city and district-wide scale, such as the new McGee Graduate Entry Medical School, but also community-led initiatives such as the Zero Waste Northwest Nappy Library, green and blue spaces within our city and district, and our climate adaptation plan, which is leading the way on the response to the climate emergency. This is a photograph of our partnership, or some of the partnership that is involved in leading the Healthy Cities initiative here in Derry City and Strabane. So there are representatives there from the Northwest Community Network, the Ulster University, the Council, the Western Trust, the Public Health Agency, and the Chamber of Commerce. And we're really delighted by the response and the commitment that we can see from partners right across the city and district to the Healthy Cities initiative. So just want to go on to the next slide for me, please. I just wanted to recap, if you just click on again, recap on some of the key points and what we've learned so far on our Healthy Cities journey. So remember, I suppose, that complex problems require complex partnerships in order to develop complex solutions, and that it's worth investing the time in these in order to develop better and more sustainable outcomes. We know at times that working in partnership can feel like a challenge, and can, in the first instance, maybe require more time for projects to get off the ground. But I would really argue that that is valuable time invested in developing shared solutions that will last and make a real difference. We also know that, sorry, if you go on to the next slide, yeah, that was my previous slide, yeah. We also know and have reflected on the fact that health matters to everybody. So that's a great opportunity really to take advantage of engaging with partners, and we would encourage you to do so. And don't make, so I suppose the message really is keep talking, keep engaging, and keep listening in order to make better decisions and to achieve better outcomes. And then I think the final slide now is just a look at what our key themes are for our Healthy Cities work on the ground over the coming year. So our three key themes are healthy food for all, active lives made easy, and warm houses, clean air. And these are the three key themes that we will be promoting and develop collaborative projects on in the coming year. And we're really delighted that that fits very well with the priorities of our partners. And reflects work that is already ongoing in the city and district. And what we hope to do is to bring external international best practice examples, as well as collaborative action on those locally here in Derry and Strabane. And finally, just to say that if people are interested in learning more about our Healthy Cities work and staying in touch with us or coming along to one of our events, we have a mailing list that we can send a link to for you to sign up to if you'd like to hear more. Thank you.
Thanks very much, Erin. I think I was very struck there, I think, by one of your initial kind of opening remarks in terms of what is a healthy city, and that it is not perfection from the outset, but more so that it is a commitment to health and a process and a structure, then putting that in place to achieve it. And again, that message of collaboration and working in partnership, and indeed complex partnerships for complex issues, for complex solutions. I think there's a very important message within that. And I guess key to that then is the evidence base in terms of leading to integrated action and those solutions that we so badly need. And our next presentation today is Katrina Mullen, who is an independent consultant and a senior research associate with ICLRD, and indeed a very good friend of ICLRD's over the years. And Katrina will be talking to us on negotiating the complexity of health in a cross-border territorial cooperation. And Katrina is currently in Dublin Airport battling queues, and so very kindly has recorded her presentation for us. So we'll play that now in a moment, and then Katrina will join us hopefully for the discussion that will follow our respondent in a couple of minutes. And so just again, in terms of that discussion, please post your questions into the Q&A function at the bottom of your screens. We have three excellent speakers here who are willing and wanting to engage with you on these really important issues. So now, without further ado, though, we will have Katrina's presentation pre-recorded. Thanks very much, Anne.
Good afternoon, everyone, and thank you for the opportunity to prepare my contribution virtually for the seminar this afternoon. I'm hoping to join you for the panel discussion, which is subject to me getting through Dublin Airport, so fingers crossed. I'm just going to share my screen now and take you through the presentation that I have. If you will just bear with me for 1 second. And hopefully this will be a smooth transition. So the title of my presentation is Negotiating the Complexity of Health in Cross-Border Territorial Cooperation. You'll have heard from Gavin and Erin about specific place-based well-being solutions that I'm very glad to see are well underway in Northern Ireland. We understand a lot of that stuff. And I'm going to talk specifically about some of the challenges of working on a cross-border territorial template for health and for population health and for health service collaboration, two intrinsically linked things, but they do have distinctive issues associated with them as well. So the overview of this is I'll talk a little bit about the matter of border regions and population health and health inequalities. I'll talk a little bit about EU cross-border healthcare and health issues, drawing on the ABR DG Santé study, which I led last year, which was looking at cross-border patient mobility in specific cross-border territories within the European Union. I'll talk a little bit about the role of data as an enabler for cross-border territorial cooperation for health and for service planning. And I'll outline some challenges and opportunities, rules of thumb, best practice, and provide some final reflections on why border regions are important and why getting it right in border regions is important. What we know about border regions and health, we know that they're on the interface between two or more public administrative systems, depending on what your land border looks like. We've only got 2 systems to contend with. Other border regions in Europe can have up to 5, which makes for interesting dynamics when you're coming to cross-border territorial cooperation and spatial planning. Border regions are a unique health economy. They frequently experience barriers to accessing services, and the population experiences health inequalities. Multiple deprivation and health inequalities generally overlap quite closely. We also know that where there's post-conflict issues in a border population, which has taken on a new relevance in Europe in the last 3 months, that there are additional complexities to understanding and resolving health inequalities. We're having this conversation in the advent of the COVID-19 pandemic, which was a pretty stark reminder of how important health and health baselines are and health status is for your health outcomes, and a particularly important reminder of the role and the agency of socio-economic determinants of health, in that those who were disproportionately affected by the pandemic and experienced higher morbidity rates were those with poorer health status globally. We have a duty to embed the learning from this, not just in terms of creating resilience and legacy of the learning, but also, I believe, in terms of remembrance of those who died during the pandemic. We also need, in border regions, particularly in Ireland, Northern Ireland, to understand the interaction between mental and physical health issues and how those relate to territorial spatial planning, because prevention and early intervention and overall well-being are huge factors in both mental and physical health outcomes for people of all ages. This is a brief look at an unintegrated map of deprivation in the border region, but it does give you an idea of the kinds of socioeconomic determinants of health that are prevalent, particularly in the west of Northern Ireland and in the northwest of the island of Ireland. There are also pockets of multiple deprivation in other parts of Northern Ireland, such as Belfast, which are very clear on the map as well. The study, excuse me, that I'm going to draw on for some of my main lessons today is one that was commissioned by the European Commission last year through DG Santé, which is the directorate that deals with health and healthcare and patient mobility and public health and everything to do with the pandemic really as well. And the purpose of the study, which I led for the Association of European Border Regions, was to feed into the 2022 evaluation of the European Cross-Border Healthcare Directive. We basically wanted to look at 4 cross-border territories and to understand the conditions in which cross-border patient mobility was taking place, but also to understand where the data was on that mobility, with a view to developing recommendations on future approaches to data collection on patient mobility that could also be used for the purposes of wider regional territorial cooperation on health and for service planning processes. The overall observations that we had were quite essentially that where there are strong civic structures for cross-border cooperation in border regions, there are generally higher levels of patient mobility. Strong local government on border regions engaging with the issue of health and well-being is a very positive determinant of the future health of the population. I refer you there to the WHO Europe review of the social determinants of health. That's referenced in my final slide. We also concluded that data is collected obviously for different reasons. It's not all collected for the purpose of planning better health and healthcare in border regions, but it could be. So we have recommended the establishment of pilot data collaboratives in the case study regions that we covered, which were Meuse-Rhine, Grand Est France, the Austria, Czechia, Slovakia area around Gmünd Hospital, and the border between Poland and Czechia. We also believe the recommendations have a strong link to the Smart Regions agenda, and we very much framed all of our recommendations in the context of territorial cooperation policy, because we believe that the regional cross-border territorial template is actually the place in which these kind of innovations in evidence-informed shared service planning for health and for population health can be achieved. And in that, we also identified the context, the concept of active subsidiarity, which means essentially member states continuing to have control of their health systems, but working actively with their border regions, in particular at that subnational level, and border regions working with their member states to create those strong multi-level governance relationships that can help to achieve better spatial planning, better cooperation in cross-border health. Better data, basically, we all know, leads to better levels of service. It also not only contributes to better quality healthcare services through looking at spatial complementarity for things like clinical specialties being retained in a border region, but it also allows then for the development by other actors, such as local government, such as other authorities, the planning of interventions that can contribute to better health outcomes for a population. And I know that's largely where the focus of a lot of people attending today will lie. And we also believe that, you know, if border regions are doing innovative things with regard to data and evidence-informed shared service planning in health and health cooperation, that is a way of contributing to the wider polity within their national states and within their member states in a way that builds border regions as assets rather than sticking with the traditional perception of border regions as a drain on resources. In terms of the challenges, if you want to do territorial cooperation for health, essentially you need to make sure you've got the right decision makers at the table. You need appropriate levels of involvement from the various levels of governance and seniority within the agencies who need to be around the table. Member states need to understand the benefit of working with and within their border regions, particularly for their health systems. That is an opportunity rather than a threat. Economies of scale can be created in terms of shared cross-border catchment feasibility models for healthcare infrastructure investment, like the Cancer Centre at Derry, like the cross-border PCI service at Derry, and like the all-island paediatric cardiology network that we have here. There's also a huge importance in demystifying data culture, in people understanding that they don't have to be a data specialist or a statistician to work with data. There's a responsibility there not to scientize it. There's a responsibility there to develop a culture of working with data. And it's also really important to have the people who are not the data specialists in the room, because if you just have the data specialists in the room, the data doesn't go anywhere. And I think that's a lesson that's been learned from a number of other attempts at working on cross-border data collation. So it's, again, something that was reinforced by our research. We also believe that there's a lot of very vague interpretation of GDPR. Sometimes it's used as a reason not to do things, particularly when it comes to exchange of data and collation of data and aggregation of data across borders. But you have to remember that anonymized statistical data is not a breach of GDPR, and that's actually a good practice way of doing business and informing yourself about how well you're doing. Models of good practice are listed there. I've already referred to Gmünd in Austria. I've mentioned the ones in Ireland, Northern Ireland. I'm delighted to see that Derry is back on the map in terms of the World Health Organization Healthy Cities agenda. There's also a very interesting model in Meuse-Rhine region, which is EU Prevent, which is an initiative specifically aimed at tackling complex social and economic inequalities, and health is a huge component of EU Prevent's work. And we also, of course, have a long-standing partnership of the health services on the island of Ireland in COT. terms of overcoming complexities in health and territorial cooperation, I think the key lessons are you need strong territorial local government actors taking ownership of the well-being of their people, with a mandate, with an interest in the population health in their region. You need strong relationships between local government across borders. You also need strong relationships between regions and government administrations. And we also have a very politically advantageous position at the moment in Europe, in that the Commission has recognised border regions as laboratories for European integration and cohesion that can contribute to a wider innovation agenda around cohesion across Europe. It's also hugely important to understand where the data is, who has it, when you're starting off, not to ignore the gaps, because the gaps themselves tell a story. And if you go after that story, very often that story can lead you to your solutions in colouring in the data gaps. Some data is better than none, but working together to develop shared approaches to collaborative, evidence-informed territorial cooperation in health is the only way forward, in our view. It's important that we get territorial cooperation in health and healthcare right, because we are probably facing into another global pandemic sometime in the next 10 to 20 years. We need to embed the learning while we have time. We need the deepened institutional cooperation, which is translated beyond the symbolic into active working processes, which are informed by evidence. And again, I don't need to preach to the converted on that one. But it's very important that we get this right now while we can, because these kind of relationships and mechanisms and evidence-informed working can prevent the kind of disruption and abruption that occurred on borders across the European Union during the COVID-19 pandemic. That also extended to workforce barriers. People who were healthcare workers couldn't get across the border to work. Safe services couldn't be operated as a result. This stuff really means it is actually now a matter of life and death to get cross-border health and healthcare territorial cooperation right. 40% of the European population lives in the border region. We are not peripheral, we are central. You can go across Europe and avoid capital cities, but you can't do it without going through border regions. We also have huge emerging challenges with regard to population health, the health of displaced people as a result of the war in Ukraine. There is a particular priority in understanding how health and population health can be handled in the context of a huge movement of people that we've seen in the last 3 months, which has been unprecedented since the end of the Second World War. So the role of border regions and their actors is crucial, and getting to grips with data and how to work together around data to make decisions for health and healthcare in border regions is really the way of the future, and it is one of the biggest political priorities facing the European Union and its member states as we go forward. Those are my sources, and this will be shared with you, so you can check those out in your own time. And I'd like to thank you for your attention and hand back to Caroline as moderator. Look forward to joining the conversation later. Thank you very much.
We've had 3 really interesting presentations, each quite different, but with a lot of common themes running throughout them. So now I'm going to hand over to our respondent, Audryn Reid of TU Dublin, who is going to pull this all together for us. Over to you, Audryn.
Oh, I have no intention of pulling it together. I think I'm going to mess it up. That was very, very interesting. And as you say, Caroline, quite a lot there that actually has a huge amount of overlap. First thing to say, like health, you can define that as the absence of illness. And that's a simple definition, but it's also to do with quality of life. And I think what everybody else has been putting it in here is that element of quality of life. And that rolls all the way through. Just Gavin was talking about livability and how the urban environment impacts on health. Now, a lot of what we've heard is very much about kind of mobility, but a key part of this is also mental health. And I think those of us who have lived through COVID, and I'm chair of a local counselling service, and we're now inundated with people who are suffering post-COVID. And we've seen in our own universities the impact that has had on students and indeed on ourselves as lecturers. So just when Katrina mentioned getting ready for the next pandemic, I'm not quite finished with this one. And but I do think what we've done is we've learned an awful lot because of the pandemic. Those of us who are lucky to have lived in reasonable places or near parks versus those who actually have lived in 1-bedroom apartments with no social ability around them, the capacity of the urban environment they have. And we do know the thing of poor places and poor people, and that kind of rolls through what we actually heard as well from Gavin when he was giving a feedback on people's perception, saying that health is terribly important and the city should be encouraging that, but they don't always feel that that's happening. And we've seen that here in Dublin as well. And we've seen those kind of quick flip overs using streets far better than they've ever been used before. And people are feeling an awful lot better about it. One thing that runs right through, I think, everybody's presentation, that's the word data. And I really think it's also incredibly complex because, you know, particularly in cross-border areas and even cross-administrative areas between local authorities, who's using what data in the same way? How are you collecting it, or are you collecting it? And we know from some of our local authorities that that's a really weak point. The same thing is, can people understand what they've got in front of them? And data has to be understood, not just by the people who are making it, but by absolutely everybody else. A really interesting thing on the news today, and I'm sure there'll be great solace to everybody, house prices have slowed down. They've gone from 15% per annum to 14% per annum. And there's a way to misuse statistics to saying that's good news. That's just bad news with tiny little salt put into it. So the other thing, again, and it's when Katrina was mentioning Ukraine and its mass movement of people, the one thing that hasn't come across in the presentation is climate change. And that adaptability that we actually have to do, and that mass movement of people is probably going to be minor as climate change adapts. And people have to move out of really, really hot areas. We've already seen 40 degrees in Spain, Greece, and parts of France. I can't imagine what that kind of climate's going to be in Africa as well. Now, just on taking up on this one, the idea that you can get 260 responses, by the way, to a good seminar or survey in Belfast is really, really good. But Gavin mentions the technocratic and economic impact. And I would say that I completely agree that we actually have to question, are we trying to develop something that's strong for economics, but actually ignoring health? And I think an awful lot of what we're doing in terms of our society is looking at that. Why has planning intervened in the past? And it is about health. It's about housing, it's about poor sanitation, it's about sewerage and everything else of those types of things. We've replaced that with a lot of other things like cars and mobility, and actually creating a different level of pollution. And some of the solutions we've come up to in the past, we're now actually having to redo and relook at. And I think what everybody else has talked about here is exactly that. From healthy cities and identifying a level of cooperation that's necessary between organizations. And that is really, really difficult thing to do. I often, from my own work in local government, local governance and local development, cooperation isn't between organizations, between people. And if you've got two people who have a capacity to do something and are willing to move things, things will happen. If you've got somebody who is holding a budget and won't move, then you've got a problem. So the question comes when we're trying to develop, we're trying to actually make these things work. It actually is about getting people who have a mandate and being told to do what they have to do. When we're trying to do this whole question in terms of trying to solve complex problems, they do require complex solutions. And I think everybody's identified the complexities that are here. And I think Katrina's description in terms of different cross borders and cross regions and cross local authorities. Those who actually cooperate, very much like what Derry and Donegal do, they can actually make an awful lot of things happen very effectively. They join things together. They don't just work between local authorities, but they've actually engaged with police services, with health services, with a whole range of things, and share budgets, which makes it easier to address complex problems. I have worked in one area where we developed a health program, one on healthy food made easy and one on smoking cessation. The smoking cessation, unfortunately, was designed for the well-being of the health workers, not the well-being of the people who are going to stop smoking. So sometimes we actually have to work and look at that one. We have the saying, health is your wealth, but only if you're not poor. And I think some of the points that have been raised here is in terms of the determinants of what health is, and a lot of that is to do with income, where people live. So the predeterminants that have come through in all the presentations identify that poorer areas have poorer health outcomes. And we have also moved, I think, more towards centralized societies. Even our health system has gone to centers of excellence, which basically mean people who are further away have more difficulty in accessing health services. I know from, again, working in very disadvantaged areas, those who take up health interventions are considerably lower than those who actually do it from wealthy areas. And there is a predetermination in terms of how people think about their own health. One thing I would say, and it's a really good quote coming from Galbraith, where he basically says what's called sound economics is very often what mirrors the needs of the respectably wealthy. And I think when we're doing and looking at this complex issue, the idea of doing complex solutions is not something that some of our governance agency are particularly good at. We have very, very good policies. Our level of implementation seems to be quite poor. I must admit the contributions that made from all of the speakers and that focus on kind of the healthy cities approach is to be welcomed. But I do know that the difficulties we've had, particularly in the south, of actually getting strong, healthy cities up and operational has been probably stymied, dependent on different capacity of organizations to work with each other. So again, just the final point again in terms of where Katrina was contribution, I think that level of interregional operations is something I think that the European Union has to be congratulated on. If we have to address a new pandemic and a mass movement of people and addressing crises into the future, having a system where regions can actually be interoperable and not just be determined, as we saw at the early stages of the pandemic, where borders were closed and peoples were cut off and people went into panic mode. I think that systemic thing is really necessary. And in an island the size of Ireland, I think it's not just a matter of having a border, it's actually even in between two different local authorities. That intergovernment action and capacity to actually share resources is going to be critically important. And I'll pass you back now, Caroline.
Thanks a million, Audryn. Again, a lot there to digest and to take away. Can I invite all our speakers to turn on their cameras, please? That's great. Katrina, are you with us? Can you hear us? Yeah. You're on mute, Katrina.
Caroline, I just sent you a message to say I'm about to drop my bag. I'll be back on in a minute, so if you can just bear with me, okay? Thanks.
No worries at all. So I suppose kind of as our delegates continue to post questions into the Q&A, I suppose I was struck by, I think we're all in agreement that health matters to everyone, but it cannot be a siloed issue, and it really has to be integrated into everything, and that includes our spatial planning policy and praxis. And there are many ways of doing that, but actually that integration in it of itself is not easy. And I suppose looking, Gavin and Erin, through your work on the ground and the initiatives that you have been involved in terms of achieving that integration, would you have any kind of key pointers for our delegates in terms of how to do that, how to make that happen effectively, or at least what are the initial stepping stones to get on that journey? Who would like to take that one first? Gavin?
I'll kick off, yeah. Yeah, and I think as echoed across a lot of the presentations that there is definitely progress being made. I think you can see from what I've referred to and Erin and others that health and well-being, I'd say, is definitely on the policy agenda for planners and for other professions as well across government. But I do think there is still a challenge around coming back to what Erin talked about and Katrina about the cooperation, the collaboration. I know we keep going on about partnerships and partnership working, how important it is, but there is still much more to happen in that interface between certain sectors. So for example, I think while it's positive that we have policy from the built environment professions and, within planning teams, community planning that talks about improving health, I would still question to what extent, the thickness or the cooperation between teams is really producing the necessary outcomes that we wish for and aim for. And so therefore, there's possibly ideas that could work in terms of job sharing, so comments between health teams and spatial planners. And I know that's gone on elsewhere outside of the Island of Ireland context, so which has been really helpful for spatial planners to know what health data is there, how the health service works, what's going on in those big government departments and vice versa. That might help to build up those relationships. A lot of it does come down to relationships between the agents in these arenas, which is spatial planners, health professionals, but also there's something to do about the overall structure, how we govern a place and how that can really support that better working relationship. And again, I didn't touch on it too much in my presentation, but it is something we explored with other experts in our team about data sharing, and it does echo a lot with what Katrina and others have said. We can do much more with the data we have. There are definitely data gaps that we need to explore, but we have a wealth of data these days that we are not maybe using to our advantage across different teams and sectors, which some of it might be due to, again, I like the way Katrina maybe expressed it and write it down, but the fearfulness of coming at data and not sure about it, I know to share it or not, and GDPR and all of that, but we're undermining the ability of ourselves as a society to function well by not using that data well. So there's things like that I think would really help in terms of progressing this much further. The idea of embedding health outcomes within sectors such as the built environment professions.
Thanks, Gavin. Erin, anything to add to that?
I guess I just agree with an awful lot of your messages there, Gavin. I think that the structures that we operate within are actually not designed or built for integrated thinking, and we are still challenged by silo thinking, and it is a challenge to get out of that way of thinking, and for me it does come down to leadership and culture, and we know that now we're looking at the development of an integrated care system across Northern Ireland as the way that we will design and commission health services, and there's lots of discussion going on about that and about what the structures look like, but ultimately the success of that will come down to relationships. So I think it is about the individuals, it is about individual development, individual learning and relationships that can be built from the ground up. So I think the idea of secondments are a great one, and I'd be a big advocate of cross-sector learning, and I think there are lots of really interesting models that we could think about that would facilitate that. I also think that we need to put much more value on open facilitated spaces for people to come together, to network, to learn from each other, and that will lead, I believe, to future collaboration. I think it's always interesting when you go into a room and allow people that space to network, and albeit that's been difficult over the pandemic, coming out of that you always get great anecdotes of brilliant partnership working that has been sparked just through a conversation. So I do think anything that we can do to remove silo thinking, and I think that actually even exists within agencies, our big public sector agencies, never mind getting into working across agencies. So we do have a lot of work to do in that space. So I think anything that we can invest in networking, leadership development and cross-sector learning would be well worthwhile.
Thanks a million, Erin. Absolutely agree totally there. Barton, I'm going to come to you in a moment in terms of, I suppose, future education of our planners. But Katrina, I suppose, if you can hear us okay, picking up on that whole area of integration and data infrastructure and the evidence base, did your work with AEBR and DJ Sante throw up any particular recommendations on what we need to do to ensure that, I suppose, we move away from these limited data sets, and also then in terms of the data sets that we do have, how we better utilize those on a, I suppose, a cross-sectoral basis, that they don't, even the data sets don't become siloed.
Thanks, Caroline. You're all going to have to bear with me here because I'm in the security queue and it's moving fast, but there are thousands of people in it. So I hope you can hear me okay. Yeah, I mean, the thing, I suppose, that the study threw up was an awful lot of the data on patient mobility is held by health insurers. And when I refer to insurers, I mean also the national health insurers, so the National Health Services, where the insurer is nationalised. And it really depends on the quality of data collection within those institutions, what is collected. Actually, Ireland and Northern Ireland have historically reported extremely high quality detailed data on patient mobility, which goes way beyond the number of procedures and reimbursements for particular, hip replacements. And it does provide quite a lot of demographic information on the patients. We sought to reference that in the report because we weren't allowed to use Northern Ireland and Ireland as a case study because of the political environment surrounding Brexit at the time, even though it's actually one of the best practices in Europe in terms of the quality of the data that's reported on to the Commission. I would say probably, if you're going to collect data, if you're going to design a data collect for, the purpose of a particular program or objective, whether that's financial or operational, consider what else it might be handy to get at the same time and do it at the same time. There's a great benefit, and I know this because having worked in the health service, I know the kind of design that went into things like the electronic patient care record in Northern Ireland. Just little simple tweaks in terms of the actual capture template can yield lots of, really useful, rich statistical data. So it's not necessarily a question of reinventing the wheel. It's not necessarily a question of building something else. It is very often a question of looking at what your current templates are and looking about how those might be tweaked in a little way to gather a little bit of extra data at no extra labor to the frontline service person, whether that's the nurse or whoever. But it's really about starting with what you've got in terms of your templates. There are, I'm sure, people who work more directly with data that I do know, there are plenty of databases that have these kind of dormant fields that aren't captured because there's no reason to put the input to actually input the stuff. So I think that was the main thing, was really look how easy would it be, for example, if you already know you know, the number of patients that you've reimbursed for, you know, hip replacements or for dental treatment, would it hurt to know what age they are and what gender they are? You know, it would probably be quite easy to get that information or to capture it. So some of it's just in mindsets. Some of it is just in mindsets that, you know, insurers will go, well, we only need to know about finances, so that's the only thing we're going to capture. Whereas actually for their own business performance, they ought to be interested in the nature of their client base and their patient base. So some of this is actually just about good business performance management. It's not even about, you know, shouldn't be about persuading people to do something that feels like it's beyond their remit, you know. So you should know your patient base, you should know your client base if you're running an insurance business.
Absolutely. I suppose just even for spatial planning, when we look at the changing demographics of our island and as we're getting older and how we need to universally design for that, I think there's integral kind of components there in terms of the health. Sorry, Katrina, I'm very conscious of time and we're actually slightly over our allocated time. So if you don't mind, I'm going to move just one last question over to Audryn in terms of planning and education, and indeed the education of our future planners. And I know that, you know, there's similar questions also needed to be asked of our health and our medical side. But it was from today's event, what are your takeaways in terms of, as a planning educator, you know, what needs to happen on that side as we try to reconnect planning, health and well-being? Yes, we're making progress, but much done, much more to do, I think would be kind of one of the inferences we would take away from today. So from your perspective, what needs to happen?
Okay, one of the issues about planning and planning education, well, planning itself, is the trolley is getting bigger all the time. And there's so many more things going into it. And it really is a multidisciplinary discipline more than anything else. What we're finding, particularly when a master's students, is that they're coming in with their own discipline, and it's very hard to shake their heads out of their own discipline and get them into this kind of thought process that what they do has an impact on health. And that includes from property and property prices and the impact that has psychologically on people with just building things. What we try to do is to encourage and to de-leaving start people's brains and get them to think and not just answer questions, and to think that health and other aspects are really key to an overall picture. And by the time that they're finished, that they have this kind of integrated approach, that they'll be able to look at and understand that the decisions that they make are really critically important. We had an open school session yesterday, and we invited lots of people from other places, and 3 of them came up to us and said, that's what you do. And I think what you said about the medics and things like this, they don't get this thing at all either. They don't get that, like, health is something they fix and do things. And I think if that proactive and positive health and doing other things, and where people live and why they're poor and everything else, some of those doctors are absolutely brilliant. The rest have a different background. And I think we have to go deeper into our education system much earlier and get people. I mean, I hate the idea that we could be dropping history or geography from curriculum, because we actually need people to have a broad spectrum of thought process. Health is, we started teaching health impact assessments as part of our program, and then find out that nobody is doing them. So, you know, I think everything we've done in terms of planning has been over the top, and we have to simplify it and say, why are we doing it and how does that integrate with something else? And I think a lot of the time we chase the elephant that's in front of us and forget there's 2 more coming behind us, and a couple are still mentioned behind us as well. So, and that's the complications of doing planning at the moment.
Thanks, Audryn. Well, I'm just very conscious of time, and we've actually gone over our allocated time slot for today. So to draw things to a close, and I know we could stay here having these conversations for much longer. There's so much to unpack here. But firstly, thank you to our speakers today, to Gavin, to Erin, to Katrina, and our wonderful respondent, Audryn. Very big thanks to Anne in the background, who has kept everything running so smoothly. And thank you all for attending today. As noted earlier, all materials relating to this afternoon's event will be available shortly from the ICLRD website at www.iclrd.org. Keep an eye out for the details of our next event. We're taking a break now over the summer, but we will be back on the 21st of September for an event focusing on planning for resilience. So thank you again for your participation. I hope you have found the event informative, and we hope to see you again soon. Bye for now.